Hi everyone, this is Samantha, the Training Manager at Health HIV. Thank you so much for joining our webinar on program income for Ryan White Part C and D programs today. And this is specific for those of you in New England, so thank you so much for being here. We're glad it's a pretty small group. We have a couple other people that we anticipate joining, but hopefully there are plenty of time for you to ask questions. So before we begin, just a little bit about Health HIV. We have 4 core capabilities: capacity building, advocacy, health services, research and evaluation, and education and training. This program is run through the Education and Training Department. Fiscal Health Systems for Sustainability is a HRSA HAB-funded cooperative agreement. We're kind of HRSA HAB's fiscal health TA arm. We provide training and technical assistance. We have regional trainings, and we also do a lot of individualized technical assistance. If after this webinar you find that you're interested in technical assistance, please feel free to contact us. And TA and trainings are free to all Ryan White funded organizations as part of this cooperative agreement. So we have our slides available for download. If you click on the little folder icon at the bottom right-hand corner of the screen, you can download our slides now or anytime during or after the webinar. We also are going to leave some time for Q&A responses, and we're recording this webinar, so it will be available both on our website and on the Target Center in the coming weeks. In the folder, you will also find a link to our evaluation. We would love for you to fill this out. It's totally anonymous, and it gives us a good sense of, if our webinars are meeting your needs, and if you are interested in finding webinars or resources on other topics, that's a great way to let us know. If you have any questions, you'll see the chat box below where you can type to us. Again, this is a great small group, so we'll be able to monitor your questions well. If you want, you can also send us a direct message if there's something that you don't want to broadcast to the whole group. Before I turn this over to our presenter, Jenna Collins, I'd just like to introduce her. She currently serves as the Research Protocol Manager for HIV programs at the Ryan White HIV/AIDS program funded Bluegrass Care Clinic at the University of Kentucky. She initially served as the clinic data coordinator, but she now serves as the program coordinator and financial manager for Part C and D programs, as well as the financial manager for their Part B and ATC Center subcontracts. She is also a HRSA HAB consultant. Some of you might have met her on your site visits. Because she's both a HRSA HAB consultant and also does this kind of stuff on a daily basis, she's a fantastic resource in helping to translate some of the HRSA guidance into practical implementation strategies. So Jenna, we are very excited to have you, and I'll let you take it from here.
All right, thank you, Samantha. And thank you, everyone, for joining us today for this conversation. And like Samantha said, I do like to try to have both perspectives, both from the program perspective and doing this every day and seeing how we integrate these principles into our program, but also from a site visit side, when a consultant comes in, what they're hoping to see, what they like to see, and maybe some of the TA that they're going to give you if they don't see it in a format that they're expecting to help you kind of improve your program. So I'm excited to talk about program income today. I know this is a tough one for programs, and so hopefully we'll get through these slides in a pretty decent amount of time. So as you have questions, we can get to those. So really, the learning objectives for today, I want to talk, define program income, what it is, look at the different sources of program income that you may have as a recipient. I want to talk about allowable uses of program income, what you can do with that income to reinvest it back in your program, and then talk about the different requirements in terms of like tracking, monitoring, and spending program income. So we'll talk about the fundamentals. I want to use some examples because I think sometimes that's helpful to walk through specific examples and what program income would be coming in from different types of patients, how you can use program income, maybe some examples on how to track it and spend it, and then also the reporting of program income. So let's jump right in with the fundamentals. So the definition, in terms of what HRSA puts out from the guidance and the policy notices, the gross income earned by the non-federal entity, which is us as grantees or recipients now, that is directly generated by a supported activity or earned as a result of the federal award during the period of performance. So I like to think of it as we are taking this Ryan White funding, we're investing it in something. Typically, program income is driven by a billable service, so we're investing it in a billable service, and then based on our enrollment and eligibility processes, we're billing insurance for anything insurance will pay for. We're billing our patients based on our sliding fee scale, and those funds that come in are the income that we're expected to track and that we're expected to invest back in the program. So I really like to think of it as, this investment is this initial direct funding that we get from HRSA, and how do we use that to grow the money and invest it back into the program to make the program bigger. So that's kind of Jana's version of the program income definition. So some examples of program income. First is if you're charging clients, as you should be, if they're above the federal poverty level, if they're paying on a sliding fee scale, that would be program income into your program. If you are paying for billable services up front in terms of salary support or FTE support, if you're in an academic medical center, then those funds that you receive when you bill public or private health insurance for services that are provided to these clients, that is income as well. Any fees, payments, reimbursements for the provision of a specific service under like Medicare, Medicaid, and the Children's Health Insurance Program, that is income that you need to track and reinvest back in your program. And then also 340B, we're going to talk a little bit about that too, but the income that comes in between the third-party reimbursement and the 340B drug purchase price, that is also program income that has to be reinvested back into your program. So just to speak to that a bit, the 340B income is driven by how you were granted that status and that eligibility to be a 340B entity. So if in your application, Ryan White was how you applied and that's how you received 340B pricing, pardon me, then all the income that comes off that program is revenue for the Ryan White program and has to be reinvested back into the Ryan White program using it for allowable expenses. So if it's not, if you have a program that has multiple funding awards that might make you 340B eligible, FQHC status or some other status that's going to make you eligible for 340B, then there has to be an allocation method, whether that be by percentage of patients that are seen that are FQHC versus Ryan White, some kind of way to determine that these are the patients that are served. Part of our application was based on FQHC status, part of our application was based on Ryan White status, and if that's 50-50, if that's 75-25, whatever that split is that you can document and justify, that's how your program income should be divided up too. So it's very important if you have multiple funding sources to look at how that funding is happening so that you use the Ryan White funds on the allowable cost, but if you have other funds that you can use for other agencies, agency expenses, that you have the ability to do that. So it's very important that you have a reasonable allocation method that you can attribute both the cost and the income that's coming in from your 340B program if you're multiply awarded, and that you document that. That is, when we come in to do a site visit, we want to see all of this documented. It's not just an idea. It's not just a policy or procedure in place. It's let's see the spreadsheets. How is this income documented? How is it coming in? And how are you spending? So making sure you have a documented methodology that you use is really important. So the things that aren't program income, rebates, the return part of a payment, that's specific to ADAP. Any credits, transactions that offset or reduce expense items that you can put on the federal award. Any discounts that you get in advance of a payment, and any interest earned on any of the above funds are not program income, and thus not, you don't have to track those and show how those funds are reinvested back into the program. Some of the other program income requirements that I wanted to mention is that as programs, we are to maximize the service reimbursement available from private insurance, Medicaid, Medicare, and any other third-party sources. So I want to describe the difference between maximizing versus supplementing. So we'll have an example later, but if you have a service that you offer that, say, costs your agency $150 and you agree to accept $100 for Anthem, that's what you accept, the $100. That $50 difference cannot be covered by Ryan White funds. That's what's considered supplementing. So you have to think of charges outside of what the agreed upon insurance rate, something that the patient would owe or the difference there. That's what Ryan White can cover, not the difference between the full charge and the accepted rate. So programs are required to track and report all sources of reimbursement on their final financial report, their FFR, and then they have to make sure that that income is used to further the objectives of the program. It can't just be used for all of your other agency purposes. It has to be reinvested back into the HIV program for allowable expenses. So if you could put it directly on your Ryan White grant, you can use your income from that. And we'll talk a little more about percentages later. Also, in terms of program income, any direct or indirect grant funds, such as Part A, B, D, or F, are not included program income and can't be used to duplicate reimbursement for services funded under Part C. So I'll mention an example of this later. But also, if a Part C service is paid for up front by Part C, you can't then bill A, B, D, or F for that service as well. So you have to be careful that Ryan White is only paying for a service once and not being double billed for a service. And we'll kind of walk through some examples. So to the extent available, recipients and subrecipients have to disperse funds available from program income before requesting additional cash payments. And we'll try to talk about that at length today, what that looks like, because this becomes very complicated, particularly for programs who have 340B funding that are seeing a lot of income coming in. And even for programs, you know, that after ACA, if you're in a Medicaid expansion state, or if you have a higher population of insured, all programs are seeing a tick up of their program income, and so how, you know, balancing that with spending your grant funds and your program income funds together is quite an act. So as programs, we have to be very conscious of how our funds are being used to provide services to HIV patients. Program income for services provided within one period of performance could be received during the following period and should be used as such. So if your fiscal year ended, say, June 30th and the service was delivered on June 29th, you bill insurance and you don't get paid till sometime in July. So you've crossed over into performance periods. You should use the money when it's received, during the year that it's received, not necessarily when the service happens. That gets pretty complicated if you try to track back to that. Because C&D have multi-year performance periods, there's, you know, a little more wiggle room in terms of spending funds, whereas A and B have 1 year to spend it in. So we do have the comfort, I guess, of multiple performance periods to spend the income. But there really is significant budgeting required to make sure that as cash payments come in, they're reinvested as immediately as possible back into the program. So let's look at some examples just so we're all on the same page in terms of what program income is, because once you understand what program income encompasses, it's easier to track because you know this is the money I'm looking for, this is exactly where it should show up, and that helps you approach your accounting department, it helps you approach your billing department with a plan of this is the income we expect to see, how can we get reports, how can we get this information funneled down to our program. So let's look at Mike. Mike is a HIV positive person who is below the federal poverty level and is covered by Medicaid. And he receives care at what's called the organization CARES, who's a Ryan White Part C funded entity. And CARES uses Part C funds to support the salary of Dr. Jones, who's a primary care physician that provides HIV medical services to low-income individuals living with HIV. So I want to first go back to that example of supplementing. So if CARES provides a service to Mike, and the service cost CARES $75, but they agree to accept $55 from Medicaid, then that is done. That $55 is the income for that service, and Ryan White cannot be used to pay for or account for that $20 difference. So that I want to make sure that that's understood up front, that there's not a supplementing of funds there. But Dr. Jones provides medical care to Mike, bills Medicaid for the billable services provided, Medicaid pays CARES for the services provided, and that payment by Medicaid for Mike's service is program income. So that is what it looks like as a service provided that's funded initially by Part C. That's your investment. You have a patient that's enrolled and eligible in your program. The funds that come in from that funded, initially Ryan White funded service, are income and reinvested back into the program. So just to take this example a little further, let's look at Sheri. Organization HELP is where she goes, and they receive Ryan White Part D funds to support services to low-income women, infant, children, and youth. We're going to say Sheri's income is 150% of the federal poverty level, and she has private insurance through an employer. So HELP, again, supports the salary of Mrs. Walls, who's a mental health counselor, and provides services to low-income clients with HIV. So when Sheri sees Ms. Walls for therapy once a week, she's going to pay, let's say, $5 as their sliding fee scale. She has a $25 insurance copay, but based on the sliding fee scale of HELP, she's going to pay $5. And then HELP bills Sheri's insurance for the service, just as they would for any other patient, and receives $40 for the session. So there's two sources of program income in this example. One is Sheri's payment on the sliding fee scale, and the other is the income that comes in from Sheri's insurance for that service. Now, to take it a step further, if Ms. Walls has been seeing Sheri for a while, really feels like she could use a psychiatrist help, and they have a referral agreement, let's say, with the new clinic. So the new clinic has agreed to accept referrals from HELP. So HELP refers Sheri to the psychiatrist. HELP can use Part D funds to help pay the copay. Again, they can ask Sheri to pay $5 of the copay based on their sliding fee scale, and HELP can, maybe pay the new clinic $45 of the copay. HELP can bill Sheri's insurance for the service, but there's really no income that's occurring here because there's no initial Ryan White investment of funds. The new clinic's a referral source, not a subcontract, so you don't have to worry about this whole psychiatrist side being a program income driver. It's really just a fee-for-service arrangement where Part C is helping this patient, access psychiatry services with a referral source. So I want to move to a 340B example. So we'll say Mary is an HIV positive client that receives medical care from the Blue Clinic, who's funded by C&D. And so Mary's nurse practitioner writes a script for an antiretroviral medication, and Mary can take it down to the Blue Clinic's pharmacy, which has 340B funding solely based on the clinic's Part C and D status. So when the pharmacy orders the medication from the 340B supplier at $500, they then turn and bill Mary's insurance and receive $1,100 for that medication. So the Blue Clinic is going to turn around, pay the manufacturer the $500 for the 340B pricing, and then they're keeping the $600. So that is the revenue and program income that has to be reinvested back into the Ryan White program. And this is where we are seeing programs make a lot of money because they've started these programs. They've been Ryan White funded for a bit, and that's what they use to get 340B, and then they're seeing significant amounts of income coming in that they're honestly having a hard time react to. How do we invest this? Is it going to be ongoing? How do we put this back into our HIV program? And so this seems to be the one that programs are struggling the most with is this 340B program income. So let's move a little to, now that we've kind of identified what is program income, let's talk about utilizing it. So in terms of the policy notices and the program guidance, Ryan White program income is considered additive. So it means it is added to the funds that are already committed to the project or program and used to further eligible project or program objectives. So program income can, first of all, only be used for allowable costs under the award because it's being added to the program. But you also have to think of it as your program budget expanding. If you get $600,000 in direct, say, Part C funds, and you expect your income to be $200,000, then your program budget really more is $800,000 and not $600,000. And the struggle that we see programs get into is if they continue to focus on the $600,000 budget and they draw funds. They draw program income first, and then they draw their grant funds based on how it's supposed to go, where program income should be spent first. Well, then you're going to have a significant unobligated balance of your grant award because you've been rightly drawing program income. So what we're trying to help programs do is expand their thought of program income to being an inclusive part of their budget. It's not something that you have to submit. You don't have to, devise a budget and submit it to HRSA, but it's something from the program side that you really need to think, if we have this other $200,000, how are we investing this back into the program on allowable costs and allowable program expenses to really broaden and expand the program? So for Part C, just to reiterate, allowable costs are your core medical services, your support services, clinical quality management, and any administrative expenses. Since both C and D are capped pretty significantly, program income isn't capped. So you can take that money and you can invest it in some of the administrative costs of these programs because, all in all, you're reinvesting it back into your HIV program and expanding what your program is able to accomplish. With Part D, again, the allowable costs are family-centered care, support services, continuous quality management, and again, the administrative costs of running your HIV Ryan White program. So you can, any of these excess caps that your program incurs that are imposed directly on the Ryan White funding don't fit into program income. So program income is not capped on those funds. So you can invest those funds in administrative costs, quality management costs and indirect costs where they would otherwise be capped on the direct grant funds. I'm going to kind of talk about some of the unallowable uses of program income. One thing you can't use program income is to offset the salary of an individual who's at the rate in excess of the executive level 2, which is currently at 185.1. So just to give you an example, if Mr. Smith makes an organizational salary of $198,000 and is providing 2 clinic sessions a week, say, to low-income HIV patients, their salary on the grant, the charge would be like $37,020. Organizationally, it's a little more. They're actually costing the organization $39,600. That difference between the full salary FTE and the capped salary FTE of $2,580, you can't use program income to do that. So that's one thing that you can't use program income is to make up for that difference. There are also HIV-related, but kind of related, but unallowable services under Ryan White, such as needle exchange, post or pre-exposure prophylaxis, medications or medical services, and then, of course, inpatient or emergency-related expenses for people living with HIV. And I will say from a consultant standpoint, when we do come into a program who has a Ryan White service and is offering needle exchange or PrEP services, we do have to look very closely to make sure program income is accounted for in the HIV program and that those services are remaining untouched on program income because those are not Ryan White allowable services. So let's talk a little about tracking and spending program income. So we've kind of identified, program income is generated by, this HIV positive patient receiving a service or a product by a provider of Ryan White services, by a Ryan White funded program, and then it's that income that's coming in from a third-party payer. So you have to have the patient, you have to have the service paid for by Ryan White, the program paid for by Ryan White, and then any income that's coming in off that investment is your program income. So when you have that identified, you can try to think of ways to track this down. Sometimes billing agencies our billing systems can be connected and integrated with the electronic medical record. So some programs are able to go ahead and use that diagnosis code of the patient, that HIV diagnosis code, to identify income that is coming in specifically for HIV positive patients. Sometimes that's difficult. If those two systems aren't integrated, typically your registration staff does not have access to that diagnosis information. So some programs look at providers. Do you have providers that specifically provide services to Ryan White patients. So if you have a person that's funded 100%, that's easy because 100% of their income, if it's going like it should be to the HIV program, then 100% of their income should be, redirected back to the program. Where that, of course, that can become complicated is if you have like a general ID physician that's seen both HIV and non-HIV, then there has to be some other element that identifies the income that's coming in off the HIV patients versus the non-HIV patients. Another billing system modifier that I've seen programs use is location code. So if you're in a big agency or if you have different services that are going on, specifically identifying the source clinic where that billing came from can sometimes be used to reinvest that back into the clinic. So that's helpful. Sometimes if you have a physician that sees patients in multiple clinics, if they're an ID doctor and they see a patient in an HIV clinic and then they see somebody in a transplant clinic, if you have a location code that you can use to say, this service occurred in the Ryan White HIV program versus this one occurring in like a general ID program, that would be a way that you can modify your billing system to identify income that's coming in for these services. And then the other thing that I recommend programs to do, if possible, is to identify Ryan White kind of as an insurance source. So, they could be put in there as secondary or tertiary or whatever is needed to make them the payer of last resort. But if you can somehow set up a billing code that's kind of benign, you don't want to put HIV in it, but if you can set up a billing code that's benign, but that's known by the billing staff and the program staff to be the Ryan White identifier, then when income comes in off of those services, that information could be used to pull out program income specific to these Ryan White eligible services and patients. So I'm just trying to get you to think about the systems that you have in place, the people, the tools that you may already have access to, and how you can use those to specifically identify income that's coming in for this patient population. If you can get monthly reports, that is great. We have to react pretty quickly to the income that's coming in. If you wait till the end of the year and find out, oh, I've got income of $300,000, well, it's a little too late to figure out, if you only expected $100,000 and you ended up having $300,000, it's going to be too late in the grant period to react to that. But if you have a monthly amount that's coming in that you can say, okay, this month we had $20,000, so we can expect, for the year we're going to have this much, and this is how we need to reinvest it back into the program. So if you're able to get reports from your billing system monthly, that's what I would ask for right off the top if you're going to meet with them and talk to them about this. What I try to tell billing programs to do is just track the payments that are made during that month. The charge may have happened a month ago, but if you can just focus on the payments that come in during that month, that's what you need to track in terms of the program income. And so that would help you meet the requirements of tracking program income and show what you have coming in so you know what you need to reinvest. So you can collaborate with your billing accounting department and really try to figure out what breakdowns are possible. I mean, this really becomes a billing and accounting issue as to how your report can look in terms of program income. Are you able to get that patient level information? If you're able to use some kind of identifier, whether that be the patient's insurance status or the patient's HIV diagnosis code from an integrated system, then you might be able to get income specifically for that particular patient. But it may be, broken down by payer source or provider, or for 340B, can you look at medication types? Whatever really makes sense for your program. If you can, if you're working out of multiple locations, do you want your income to be divided up by your home site versus your satellite site, so what kind of income is coming in from both programs and reinvest it as such, put this money into your satellite program and put this much money into your home site. You really have to talk to your billing agency and see what they're capable of. I wanted to give you a couple examples of what some of these reports may look like. I mean, they don't have to be outrageous. You want to be able to track that back to your program. So these provider names, A through L here, those would be actual providers that are funded by your project. So you would have, provider X that's funded 20% on our project. During this month in July 2015, we charged $12,000 of services for what they provided in the clinic, and the income that came in during that month was $5,555. So That's enough to show that, if you have your criteria up there that you've determined you're going to do it by billing code or location or diagnosis, whatever you're going to use to identify that income for that provider, any kind of report that just shows, this is the services that were provided by this provider, this is how much we billed during this month, and this is how much we actually collected. So for this program, the payment is what you're looking at. So they collected about $23,000 in income, and so that's what they're going to have to, at least start to plan on. If next month, if it's $30,000, then they may have to adjust their budget. But you want to look at these numbers as frequently as possible to see what you need to reinvest back into your program. This is more of a broader income report, and it's kind of helpful if you're able to break it down by insurance source. So that's what this is. This would be like provider A, and this would be the income that came in from Humana and UHC and Aetna. So I just kind of divided this report out so you could see you have specific providers that are providing services. This is how much we charge, and this is how much income we drew in from the specific insurance agencies. And then so for this month, May 2016, the income was $15,000. And so they would need to, again, account for this. This is how you're showing that you're tracking the program income, and then you need to have a way to reinvest that back into your HIV program. So I think, any kind of systemic data that you can get on with your billing agency, if they can send you monthly reports, if they can send you more frequent reports, whatever would work with your group, but some kind of systemic reporting so that you can react to the income coming in is great. Again, greater frequency really just provides better accuracy and gives you better adjustment time to ensure that income is being spent timely and that it can be used to further the objectives of your grant program during that performance period. So I want to talk a little bit about program income being spent before requesting additional cash payments. So for as much as possible, like we said, you need to estimate how much program income is coming in. Lately, because we've seen this increase in patients with 340B programs and a higher insured population, we're seeing a lot of programs that have a lot of income that they don't know what to do with and that they really are nervous about. It's a lot of money. Do we want to take on all these new programs if the money goes away? There's a lot of anxiety, I think, about this money coming in and how it needs to be reinvested. But I was on one site visit where a program had not touched their grant money at all. They had like a week left, and they had been doing exactly what they were supposed to. They were drawing program income because they had a significant amount of income coming in, but that meant instead of spending their grant award, they were just using their program income. So their entire grant award was unobligated for that year because they hadn't spent them concurrently. And so what you need to talk to your project officer, if you have a lot of income coming in on how to do this, but there's a lot of discussion about budgeting these concurrently, not for the same service. So if you have a mental health provider that's 100% on your Ryan White Part C budget, you don't want to use your program income for that person because they're 100% funded on your direct budget. What you may want to do is hire a second mental health counselor that's funded under that program income, and now you've duplicated your service, you've expanded your services. So you really want to look at not this $600,000 budget like I was talking about before, just your Part C budget that's approved for your work plan, but looking at the $800,000 budget, looking at this $200,000 of program income that's coming in. How is it going back into the program to make it bigger and better versus just the $600,000 that's coming in? Because if you don't try to look at them concurrently and spend them concurrently, then one of them is going to be left over. And you're going to have to deal with that. You're going to have $200,000 left over of your grant, or you're going to have all of your program income left over. And the goal is to really take those funds and expand your program to serve your patient population. So that's going to take, funding projections, budget tracking, program planning. I mean, it is going to take, the same amount of work really that it takes to manage your budget because you're having this funding source that's coming in that you're reinvesting back into the program. So let's see. So I would say the best practices is really developing a plan or a budget. Being able to show a site visit team, this is what we're tracking. We expect to have $300,000 in our account, and this is how we're using it. We have these positions, for instance, that work in our grant program that make this HIV program happen, but they're not directly funded by the project. We're using our program income to support these positions to make this program full. So what you're looking at is being able to show how your HIV program is more than just this $600,000. It's more people, more services, more than just what that budget is coming from HRSA, because you have your income and you're investing it back into that program. So whether it's a specific line item budget like you have for your direct funds, or if it's a written plan on this is how it's being spent and something you're able to show, that's what a site visit consultant is going to want to see when they're on site. So really thinking about the care continuum, there's the grantees were responsible to show how we're retaining patients to care and how we're making sure they're virally suppressed. So when you do a needs assessment, you look at your program and say, we really need better mental health, or we need more substance abuse, and that's where you need to put your program income. That's what those funds are there for, is to reinvest back into your program and improve it to meet the continuum of care, to meet the needs of the patients, and to make sure that they're successfully following, their appointments and their treatment regimens, and staying virally suppressed. So let's talk briefly about reporting program income. So all programs have to report their program income on their final federal financial report. You're going to report both the income you received and how much was expended. So your project officer will be looking to make sure those numbers are close. If you brought in $300,000, they want to see that you've made every effort you can to spend that $300,000, not that you've spent $70,000 and you're sitting on the rest of it. So on your financial report, you're going to want to show what you've brought in and what you have expended. Now, I did want to mention here that you also are going to have to track that by funding stream. So if you're not solely Part C or not solely Part D and you're funded by a combination, then your income will also need to be reported in a combination. So part of that income will be Part C and part of that income will be Part D. And I would say, I know that seems to add another complicated layer to this whole process, but I think you really just need to think about your methodology in terms of how FTE are divided. So if you have a provider, let's say, who sees Part C patients and sees Part D patients, and say 75% of their effort is Part C and 25% of their effort is Part D, then it's okay to apply that same effort to their income. So if that provider has $10,000 of income coming in, 75% could be attributed to Part C and 25% would be attributed to Part D. So again, it's having a methodology that is reasonable and supportable. So if you can show that you're taking these providers, you're looking at their productivity reports, you're looking at how many patients they're seeing that meet these different qualifications, how many women, infant, and children are they seeing, how many Part C patients are they seeing, and then supporting and dividing their program income up the same way, that's what we need to see. It just needs to be a documented, reasonable amount on how you're determining how to track funding per funding stream. So in terms of subrecipients, I wanted to briefly talk about that. So again, subrecipients, their program income can be retained in their own program, but again, it's considered additive. So if you're a recipient and you have a subrecipient and that subrecipient is bringing income in, your responsibility as a recipient is to make sure you monitor your subrecipient, make sure that your subrecipient is telling you how much income they have coming in, and then also tells you how they're utilizing that program income for their program. How are they reinvesting that back into the HIV services that they provide as a subrecipient. So the program income is reported to you as a recipient, but it doesn't have to be reported on the recipient's FFR. So if you are a recipient, you're providing billable services, and you have a subrecipient that's providing billable services, the income that you report is only the income for your program as a recipient. The billable services that you as a recipient are providing, that income is what you have to report. For the subrecipient, you really just have to be monitoring them. They tell you their program income. They tell you how they're reinvesting it back to the program, but it's not something that will be reported on your FFR. So I hope that makes sense. If there are questions about that, I'll be happy to answer those. So I kind of flew through that, but I wanted to be able, hopefully that will kind of guide our discussion. If there's questions that you all have based on what we've talked about, or if there's anything that I can clarify, I'd be happy to do that. So I'll turn it over to the Health HIV team.
Thank you so much, Jenna. So folks are a little quieter, I think, than we typically have on our webinars. Can we maybe get some reactions to that presentation? Was it overwhelming? Was it helpful? Do you feel like you have some of these systems in place? Are there areas where are there specific areas where you really feel like you could use some more information, some more guidance? I would love it if folks could take a minute or two to just share some of their reactions. I know that the spending program income before drawing down grant funds is quite difficult for a lot of organizations. So if anyone has been doing that and feels like they actually have a pretty good method in place, if they have good budget systems, folks could maybe share where they're at as well. There's a question on not being able to download the slides. I'm sorry that you're experiencing that. We will be sending a follow-up email. We'll send you the slides as a PDF, and we'll also send out our evaluation link. Anyone else have questions about this? Site visit findings related to program income? Does this seem doable? And Jenna, while we have some folks who are typing in, if you could talk a little bit about some of the major things that you see when you go out on site visits related to some of that, maybe that would also be helpful for other folks.
Okay. Well, I would first say that if you're struggling with it, you're not alone, because most program sites are. It is a common finding that we have. Some programs will identify some of their program income, but not all of it. And so that's, I think, one challenge that programs have, is really looking at all of the possible sources of income that are coming in and reinvesting that back into the program. And I would say, as I mentioned previously, the biggest concern is, I guess, the stability of the income coming in. And if you reinvest that, say, in a position and then the income stops, what happens? And I think that's, it's a realistic concern, but it's the same with grant funding. I mean, we are all grant funded, and there's always a chance that could go away. And so you have to just hire these positions, giving them the knowledge that this is grant funding, this is program income funding. As long as it's coming in and we can afford it, we're going to. But if the grant ends or if the income ends, then this part of the program has to end. And so it has to be a conversation you have up front. And some employees are willing to take that risk because they want the experience, they want the knowledge that the Ryan White programs can give them, because it's unique to their programs and not something they can get out everywhere. And so they'll take that grant position or that program income position knowing that it may be short term. But if you're just upfront and educate them about that chances, then, I think you still can move forward and just, do the best you can to make sure your program is growing and you're meeting the needs of your patient and spending your funds.
Excellent. Thanks so much. So we have another, someone else is sharing kind of what they do. And Jenna, if you could respond to this as well. Instead of a secondary or tertiary payer, our method involves identifying Ryan White as the guarantor for the service. Have you seen other recipients who are doing that as well?
I think so, and I think some of the goal of that too is to get away from the patient being turned over to collections or having being harassed by bills. If Ryan White's kind of the bottom line payer or the guarantor, then that does kind of prevent the patient from having those kind of barriers to their care in terms of finances. So that's a great idea.
Excellent. Awesome. Thanks so much for sharing, Valerie. And I know some of you who might have been on this presentation who have received site visit findings related to this or are kind of starting to try to overhaul your program income tracking system. I know that this can seem a bit overwhelming, so if you need to take some time and digest what was said on this webinar and you want to come back to us for some TA opportunities or clarifying questions, certainly we are available to take all of your questions. Our email address, training@healthhiv.org, is on the screen. And I know that some of this is a little bit, as I said before, difficult to digest, so I get if we'll need to take some more time on this. Another question here, so just to clarify, you can use program income to pay for the overhead admin costs that were capped by the grant. I've heard slightly different things, especially that the sole use of program income for those costs isn't quite in the spirit of the grant. You can definitely use program income to pay for overhead admin costs that were capped by the grant. Program income isn't held to the same, for example, 10% admin cap. For some folks, that's a great use of program income. I mean, you could say it's not necessarily in the spirit of the grant and that it's not directly expanding services, but in a way it actually is. It's allowing you to pay for staff time and for other, areas of your service categories that you wouldn't be able to, which means that you are able to expand your program. Jenna, I don't know if you have anything else to add to that as well.
No, I agree with what you said. I think that they have said that you can't, that the cap doesn't apply to income, and if it would be an allowable expense, an administrative expense on the grant that, technically you could charge if there was no cap, then that would be an acceptable use of your income.
Right.
And I did want to comment on, Rodney had commented about the 340B status, Ryan White only versus multiple programs. I know this is a lot of angst for a lot of programs. If they have a 340B that was solely based on Ryan White, but they have income that's coming in from non-Ryan White patients, let's say non-HIV patients. I know this is something that a lot of programs are looking at. So I think it's really, really important for programs to look at how their percentages are determined up front. Say, like one program I was looking at was a Ryan White funded program initially, but then decided to go for FQHC status and received that. So they were expanding their patients beyond their HIV patients and now seeing non-HIV. So, our discussion with them was looking at their 340B program, looking at adding the FQHC status to their application, and then looking, how many HIV patients are we serving in terms of Ryan White, how many are FQHC, and coming up with methodology to say, this is the cost of our program in terms of the types of patients we're serving, because now we have multiple programs that support that 340B funding, and then dividing up the income as such. So I think it's really important for programs to look at that as they expand beyond HIV programs, or as they apply for 340B status.
Great, thank you. So if folks have other questions, feel free to ask them. If you would like kind of just a sound check on what you're currently doing, if you feel like it may or may not be okay. John, of course, is on this webinar, so he's a fantastic resource for that. We're also here if you have any questions in the future. So we'll stay online for a little bit. If you want to download the slides, if you want to click on the evaluation link, we'll also send both of those out to you via email. But thank you so much for chiming in with us and listening today, and we hope to see you again on other webinars or in-person trainings in the future. So thanks so much, everyone, and thanks so much, Jana.
No problem. Thank you all.